It's my pleasure to introduce our next speaker. And in the day after the symposium ended, the last time we had a symposium was when we began planning for this symposium. One of the things we thought about was we knew we wanted to have Gunter. And after we think about CDT, treating patients, the big question is, how do we keep it under control long term? And really, that's what we struggle with. And patients with lymphedema struggle with that their whole lives. And we thought we had seen a number of patients referred to us by Denise Mcintosh from the Leahy Clinic. And Dhruv and I both looked at each other when we realized, who do we know that has patients that really keep their lymphedema under control? We looked at each other, and I think at the same time, we both said, Denise. And that really sealed the deal. We decided we had to have Denise come and speak to us. So Denise is a senior physical therapist and the coordinator of the outpatient lymphedema treatment center up at Leahy Clinic, and has a very proven track record for her patients keeping their edema under control. So she has trained them well. She does an adequate, according to Gunter as well, course of CDT, but also instills in her patients the tools to be able to keep it under control long term. So we're going to have her come and speak to us about how she does that.
Thank you. Well, hello. Much of what I'm going to be saying, actually, a lot has already been said this morning. I think it's the mouse. Okay. There we go. As we all know, lymphedema is a lifelong condition that requires a lifelong commitment. This can be really daunting for patients when they hear this. It can be overwhelming. So the goal is to try to come up with something that is not so daunting and that they'll be able to manage their lymphedema lifelong. When I think of treatment of lymphedema, I think the most important thing that we need to do for patients is education. We need to teach them what lymphedema is, how it manifests, what we might be able to do to manage it. And this starts on day one. Then we have to reinforce this continuously. The more we can repeat and educate them on what's going on, the better carryover that they'll have. And then lastly, a follow-up program. Gunter just spoke of that, and I'll speak of that in a little bit. But between the combination of the three, that's where I tend to have the best outcomes. Going the wrong way. There we go. So just as a complete, just a quick review, the standard of care for lymphedema is complete decongestive therapy. It has its two phases, the intensive phase, which is the treatment phase, and then the maintenance phase, which is the home program and the self-management. The intensive phase, 4 components: the manual lymph drainage, the compression, skin care, and exercise. I'm very fortunate at Leahy that I'm allowed to treat my patients 5 days a week, as long as they need to, and as long as their insurance is covered. Typically averages about 4 to 6 weeks. There are many advantages to being able to treat 5 days a week. First, the patient hopefully will get more we'll get better outcomes much quicker treating daily. And then most importantly, the patients will be receiving therapy 5 days a week. By the time the end of the week comes, the weekend comes, they'll have had therapy, they'll have been in bandages 5 days, they'll be able to feel what the compression of bandaging is, and they'll have a really better idea of what they're going to need to do over the weekend to manage this. On Fridays, we videotape on their phone how they're bandaging the leg so that they'll have better feedback over the weekend. I ask them very first weekend to take the bandages off both days during the weekend if possible. Take it off for 2 hours. First, it gives them a little bit of a break. They can take a shower. It also gives us an idea of what kind of refill the limb is going to have after being out of compression for 2 hours. If they're out for 2 hours and they have a really quick refill, that's going to give us an indication later on of what type of compression or how much compression we're going to need to manage the lymphedema. But most importantly, it's going to get the patient to start practicing bandaging right away. They may come in on Monday and their lymphedema might be a little bit worse because they might not have had such great outcome with their own bandaging. But again, it's another way that we can reinforce right away what they're going to need to do to manage their lymphedema long term. The home program, self-management, is exactly the same as the intensive phase, but now it's all on the patient. They still have to complete compression. They have to do skincare every day, self-MLD, exercise. We can't forget elevation whenever possible. The most important thing is that we come up with a plan. This can be overwhelming, very time consuming. So we have to come up with something that's going to be as simple as possible, but very consistent. Long-term management is dependent on a few things: the extent of lymphedema, how it responds to compression, patient circumstances, and unfortunately finances. Whether it's primary or secondary lymphedema, a combination of different things, the venous insufficiency, lipedema, further stages into lymphedema, and what the stages are, if it's very, very mild or it's the severe stage. Every one of these patients are going to have to come up with something to manage their lymphedema on their own. When we think of compression, there's a couple of things we have to consider. First, the levels of compression and the length of time in compression. Some people are only going to need a very mild compression stocking below the knee, 20 to 30. They only have to wear it once a day, and that's all they really need to do to manage the lymphedema. Other patients will need to have custom compression garments right up to the trunk, have to wear some form of compression 24 hours a day. So again, we need to come up with something that's going to be able, they're going to be able to manage better on their own. Compression has many forms. When we go into treatment, the first thing, the best outcome that I get is with bandaging. If we can get a patient to bandage and bandage every day during the week, we do have better outcomes by the end of the week. The problem with bandages, they're very heavy. They're very bulky. They limit range of motion at the knee and the ankle. So walking and transfers are very difficult. And they're very cumbersome. Some people can get very good at doing self-bandaging. Take 15 minutes and their leg is bandaged, it's not a problem. Other people can take 45 minutes to an hour to bandage. And this is, again, it can take over. They'll get burnt out very quickly. So we need to, again, come up with some way that they can manage this better. The other thing that we have to consider, time, is the laundering and the rolling of all of these supplies. That's another hour that can take more of their time. When we're finished with therapy, we then have to consider compression garments. We're going to hear of garments from our next speaker, but there are many different types, many different fabrics, different compressions. Again, depending on the extent of lymphedema and how it responds to compression, that will determine what kind of compression they'll need. Many legs that are into the later stages of lymphedema, depending on the extent of how much swelling, the shape of the limb, any malformations, that's going to limit the kind of compression garment they'll have. So they've come up with the type of compression that they can use, but they've come up with many alternative compression garments, and I apologize for any company that I missed on the slide, but these garments are wonderful. They originally were designed to be used as a night garment. So someone would use their compression garments during the day and use bandaging at nighttime. This is an alternative to the bandages. Saves a lot of time, a lot of frustration, and it can be very effective. But we found that we like these so much that now we are using them with patients during the day in place of compression garments. For those who can't use compression garments, again, because of the size of the leg or their shape, or they have arthritis and they can't get those compression garments on, these are a very good alternative. Another form of compression that we don't use for lymphedema, but we can use is a 2B grip or a TG grip 2. This is just a tube of compression. It's not gradient. It's very mild, light compression. But if you have someone who comes in who has venous insufficiency and they have fragile skin, the stockings can cause some shearing along the skin and cause skin tears. So this is a good alternative to start with compression. Patients who come in with lipedema, that was mentioned this morning, they can be very, very tender to palpation, and no amount of compression they'll be able to tolerate. The 2B grip is a good way to start, just to start to build up their endurance so that they can be progressed to another type of compression. I mentioned TEDs. We don't use TEDs. I've had many people come in with TED stockings on. Again, that's just a garment that's used more for bed rest. It's non-gradient. The fabric is very coarse, and the problem is they can be very constrictive. So we've had people come in with TEDs and their lymphedema actually worsens. So we don't use TEDs. Another thing that's going to help people manage their lymphedema easier are donning aids. Simple rubber gloves, Mr. Clean rubber gloves are can make or break someone with putting compression garments on. They can be very difficult getting over the heel and then just trying to grab those garments and pull them up. So using a glove that has some stickiness to it will really make it much easier. They can grip the stockings much easier. They can get that stocking up over the heel, saves a lot of frustration. And it takes some people 20 minutes to put one stocking on using the gloves, and it's 5 minutes. That's still a lot of time to put a stocking on, but it saves them a lot of effort. Other donning aids you can use are like the Easy Slide and sock aids. They're also going to help get that garment on, especially getting it over the heel. Anything to make this easier. More about the home program and self-management. Again, everyone will have to do impeccable skincare, putting lotion on. It can become just part of the showering habit, keeping your skin soft and supple. It's going to help decrease your risk of infection, cellulitis. Everyone has some kind of form of compression. Everyone is instructed in how to do self-manual lymph drainage, put on an exercise program depending on what they need. We discuss pacing skills a lot. The problem is with lymphedema, some movement and exercise can worsen lymphedema, and other times it can help improve the lymphedema. But the problem is when a patient tends to do too much in a short amount of time, that can increase their swelling. So we discuss this at length. I have 2 patients who run marathons with their stockings on and never have an issue. They can run for miles. I have other patients who can't manage 10 minutes. So this is something that we discuss all the time during their weeks of therapy. And it's important for them to find their fine line. Once they get to that point, that's when they need to learn to back off a little bit and then gradually progress their activity as they can. Going to mention pneumatic compression pumps. I was never a pump person until recently. The thing with the compression pumps is that they are an adjunct to whatever the patient is doing. Some people think, oh, I'll get a pump and I don't have to use compression anymore. And that's not the case. The pumps can definitely help with soft tissue mobilization, can help with some of the swelling, but again, it's short term. The problem with the pumps is that they take up a lot of space. So if someone is considering using a pump, we have to be sure that they have a place that they can get it set up and leave it there. If they're having to take it up, set it up and break it down every day, within weeks, they're going to stop using it because it gets old very quickly. But again, it's something else that they can use to help take some of the stress away of doing of managing their lymphedema. And they spoke at length about weight management. And obviously everyone has to lose weight who has lymphedema. The research shows that if you're overweight, you're going to have an increase in your lymphedema. If you gain weight, your lymphedema can worsen. But the good thing is if you lose weight, your lymphedema can improve. The disappointing thing is for some people, they'll come in very frustrated being told that they'll have to lose 40 or 50 pounds and their lymphedema will be better. And they know they can't lose this weight. But we discuss it again in that losing weight will help with the lymphedema. It's just not going to make it go away. I'm going to back up just a minute. So if you look at this whole list, and if someone is doing this every day, impeccable skincare, compressing 24 hours a day, supposed to do self-manual lymph drainage twice a day, exercise twice a day, using your pump once or twice a day, and then trying to take care of your weight, it is overpowering. It just can take over. And the problem is if someone is really become obsessed with this, they will get burnt out and then they don't do anything. So we have to really come up with a plan that they can help manage this. Other things that affect long-term management are patient circumstances. Does someone live alone? Do they have a spouse or family members or friends that can help them? We have a lot of patients who come in and we'll bring family members and we'll teach them how to do the manual lymph drainage and the compression bandaging. We really try to emphasize those who can that they need to do this on their own. But if they can get help when they can, they should take the help. Finances, unfortunately, this plays a big part in what someone might be able to do in long-term management. Some insurance companies will cover the cost of garments and bandages. They're very expensive. Sometimes there's a copayment, an 80-20 policy or a 70-30 policy, so they have to come up with something, but thankfully, the insurance companies will cover something. Medicare covers nothing, no bandages, no garments. So it can be quite difficult for someone who needs to have compression bandages, compression garments, and they just can't afford it. So we're trying to come up with ways that we can help people get assistance with this. The other thing with finances is that the compression garments need to be replaced every 6 months. Again, the insurance companies will only cover 2 garments every 6 months. Can you imagine living with 2 socks for 6 months? And so people will, if they can't afford it, they'll go longer times, a longer period of time without replacing their compression garments. The compression garments will then get stretched, and then their lymphedema will worsen, and then they can't fit into the garments at all. So it plays a part in their ability to manage their lymphedema long term. The last thing is follow-up. We try to really be sure that we have a follow-up program for our patients. They go, like Gunther said, they go out the door, and if they're not, they don't have plans to come back to see us, they can lax in their self-management. With what we've done, the problem with follow-up visits, it would be great if someone could come in once a month and get a treatment, or once every 3 months and get a treatment, but insurance doesn't cover that. That's considered maintenance. And so we can't get around the system that way. So everyone should be replacing their garments every 6 months. So what we've done is to make it so that it's affordable. We have a fitting clinic that's held every Thursday morning. We have a wonderful DME vendor comes in. She sees new patients and returning patients for measuring the garments. She's right in our department in the room right next to me. So as a patient, one of the old patients comes in, I'm able to pop in, say hello, do a quick assessment, see if they need to have anything, any further intervention. And with this, it's giving the patient some more reinforcement, another person to say, yep, you're doing an okay job. No, let's try something more. The other thing that this allows is amazing. People come in with their garments and that, nope, I don't know why the garments aren't working. And you can see on the slide, these are people who have come in wearing the garments as they are. And so this will give us another opportunity to reinforce what they need to do, how the garments need to fit, and maybe spend a few more minutes with them to try to get the garments up on correctly. So in summary, with long-term management, we want to try to to come up with a plan that's as simple as possible, but be consistent. The patients need to know that they need to do whatever it takes to manage their lymphedema without driving themselves crazy. If it means that they can't do everything, they need to at least do something. And compression and skincare, in my opinion, are the most important. If they can manage their compression, if they can take care of their skin, they'll at least be able to manage their lymphedema fairly well. Everything else is extra, but the more they can do, the better. But again, we can't allow them to let this take over. And then some people don't agree with me with this one, but I tell my patients that it's okay. If you're getting burnt out, you need to take a break. The problem with taking a break is that your lymphedema can get worse. And if you take a break, you just need that time. Just know that it's going to take you a couple of days or even a couple of weeks to get back on program, get that lymphedema back under control. But hopefully by the time everyone leaves, they'll know how to take care of their lymphedema without driving themselves crazy. It's key. Thank you. I hope this has been helpful.
Thank you. One question came in. Can you comment on the use of adjustable compression devices during the decongestive phase of therapy?
Yes, so that would be the alternative garments, and I use them quite often, especially for the stage 3 lymphedemas. There's a great garment when you have a smaller calf and a ginormous thigh. Bandaging can be horrible. You can use all the foam that you can muster, layering up all levels of foam, and then trying to bandage the whole leg, and that's not going to stay up. So with some of these patients, I found that by using bandaging on the lower leg, and if they have the lobules on the lower leg, you can build them up with the foam as well. But then you can also use, there are 2 companies that make alternative garments that can be customized to the patient, and they're wonderful. They slip, but it's much easier to adjust for the patient to adjust this garment than try to rebandage. And then as the leg decongests, you can cut these garments down so that it's a better fit and they're going to get even more decongestion. But I use them all the time. And again, it's another great tool for them to use as an alternative to bandaging so that it takes 2 minutes to put these night garments on rather than having to spend the 20 minutes bandaging.
Another question here, Denise, and I love this one because it really speaks to this topic of active versus passive modalities. Will you start MLD if the patient refuses to participate with compression?
No. Yes and no. I have to take that back. So someone will come in and they're adamant, this is not going to work. I can't do this. I don't want to do this. That's when we'll spend almost that entire evaluation time teaching them what this involves and at least let's try it. Some people will come in and I just want the massage. It's like, that doesn't happen in our clinic. We don't do just manual lymph drainage. If you don't compress, the manual lymph drainage is only going to be a temporary fix or feel good. So for someone, I think the point of the question is how do we motivate the patients? Again, spend the time, educate them and have them try it out. And if they come in and for the week and they can't manage it, they at least made an effort. But most times after 2 days of being in bandages, people are saying this feels really good. It's a pain in the neck, but it feels good.
Yeah. Another question here. I think oftentimes as therapists, I find myself straddling the role of like mental health therapist with physical therapist. And I heard you speak a lot to understanding the patient's underlying psychosocial context. Do you find yourself making referrals on a regular basis to like formal mental health therapy?
Yes.
Or how often does that factor in?
At Leahy, we have the first step is primary care physician, and then their nurse practitioners. We also have wonderful social services department that we can set patients up if they really need something more than the physical therapist.
And have you noticed that changing significantly since the onset of COVID? And
oh boy, yes, we were just speaking of this earlier. I'm in between sessions, and that this COVID has done a job on everyone. And patients want to come in, and they need to be seen now, and their stress level is so much higher. So we come in, we get them in our treatment room, we shut down the lights. It's like, okay, let's just sit here, let's take this in, and then let's worry about everything else later. Yeah.
We have one question from Anita asking, do you treat or how do you treat patients who also have open wounds?
I don't treat wounds. I used to. I used to work with a wonderful nurse practitioner who was a wound specialist, and she was right in the department with me. So I could treat wounds, and if something happened, I had that nurse to be as a backup. The problem with wounds is that they can turn overnight, and I'm not a wound nurse. And in the situation that I'm in now, I'm in an outpatient clinic with Leahy, which we're right around the corner from the main hospital campus, but I don't have a resource that I can send that patient to. And everyone is so busy that it's not like I can call them up and say, okay, can you see them now? I do treat superficial wounds with Una boots. I can do that if the wound nurse isn't available for 2 weeks. And I know that it's not a horrible wound. So if it's very, very superficial, or we have lymphorrhea, well, that drives me crazy. Lymphorrhea is that you try to bandage them and they're going to be soaking wet. So having an Una boot, using some Aquacel with it and changing them 2 or 3 times a week, that can make all the difference. It will dry the leg right up, and then we can start the therapy. But any wounds, no, we have 2 very good wound clinics near us, and refer them right out.
And then can you comment on aquatic therapy as an adjunctive modality?
We don't have any aquatic therapy programs in our area, but swimming is wonderful. Being in the water, 2 things: the buoyancy of the water helps you move and exercise more, less resistance. And then the compression of the water is going to give you compression. And the deeper you go, the more compression you'll have. So yes, anytime anyone can get in a pool or a lake, it's wonderful. It can make a difference. Come right out, put the compression garments on, and it can help.
Yeah, I'll have to second that. We ironically, we just got rid of our pool, dismantled it to make way for our new lymphatic center. but it was, so for 20 years we had a pool, and we did use it, to great effect in patients who had lymphedema. I explained to the patients, basically you're in a compression stocking up to your neck, basically with down your legs, your feet, you're getting maximum compression. And we used to have an awful lot of patients who then would continue on and get a membership at a pool as a way to combine exercise and help keep their lymphedema under control long-term. So put a plug out there for aquatic therapy.
Yes, we have a local Y who runs the PINK program. And so and they have the Live Strong program as well. So the patients, as they're going through the program, they have access to all of the facilities, and they really push them to get into the pool after their exercise program.
Okay, I think that's it. We're going to have to go to the next session. Thank you very much.
Thank you. This was great. Thank you.